Puneet sir, can we start the show?
Yes, we can. So, good evening, everybody. Namaskar, and I welcome you all to the API DIAS program, which is an initiative of API, that is Association of Physicians of India, for continuous medical education on various communicable and non-communicable diseases. And this program was started in 2013 by Dr. Muruganathan, who was the API president at that time, and then it was successfully followed by the Dr. Shashank Joshi, who was president after him. And since then, this academic endeavor has continued, and it has touched almost 18,000 physicians across India, and not only India, but the neighboring countries also, like Nepal, Sri Lanka, Maldives, Bangladesh, and they have benefited from our academic endeavors. And more than 400 CME credit hours have been given by this program. And since in this difficult time of COVID, where physical conference was not possible, so it has gone on virtual platform. And the few of the programs have been running since the last month, that is mid of August. And in that sequence, we are keeping this API programs on every weekend, Friday, Saturday, and Sunday, and for duration of 1 hour only, because this is virtual platform. You will be when delighted to hear that by using this platform, we have been able to reach almost 22,000 physicians across India, because the reach of this platform is much more as compared to the physical platform. So I thank Abbott for supporting this academic cause so nicely over the years, and they've continued in this difficult time also. And as far as today's program is concerned, we have eminent people joining us for the program, and I'm going to introduce you. And before that, I introduce in very short that I am Dr. Puneet Saxena. I am a senior professor of internal medicine at SMS Medical College and Hospital, Jaipur, Rajasthan. And I am a member of governing body of API, and I'm the organizing secretary for upcoming conference of Association of Physicians of India, which was supposed to be held in January 21, but stands postponed because of COVID pandemic, and we are going to hold it sometime later. The dates will be disclosed in short period of time. Now, coming to the eminent guest which we have Dr. Arul Raj with us, who is the president of Associations of Physicians of India, and he hails from state of Tamil Nadu. Welcome, sir. We welcome you to the today's CME. And in brief, he does not need any introduction because most of the physicians know about his academic work which he have done over the years. But he has been a gold medalist in MD medicine, and he have worked immensely in the field of non-invasive cardiology and intensive care, especially in Tamil Nadu, and he has developed it like anything in southern part of Tamil Nadu, especially. And he has been invited as eminent speaker on the national and the international platforms, and has been closely associated with Indian Medical Association and Medical Council of India. And he has been an emeritus editor for a journal called MediGuide, which is meant for family physicians running over last many years. So welcome, sir, for the today's program once again. Now we have our chief guest for today, who is Dr. Vinod Paul, and who happens to be a pediatrician from AIMS. And he is a very eminent medical faculty, and he has been nominated as member of Niti Aayog in 2017 by Government of India. And he also happens to be on the board of Medical Council of India. And he has been associated with many programs like Ocean Abhiyan, and he has led that vertical. And am I audible? Am I audible?
Yes, you're
am I
audible.
audible?
Yes, yes.
All right, all right. So, sir has been, Dr. Paul has been fellow of 3 science academies of the country and a recipient of Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research and the Public Health Champion Award. And he has been conferred the prestigious Ehsan Dogmatic Family Health Foundation Prize by WHO at 2018 World Health Assembly. And I welcome you, sir. And we are so proud and lucky to have you on this Sunday evening with us. You have spare time, and your guidance and kind words of wisdom will guide us further, especially in this difficult time of tackling COVID. Physicians are at the forefront. We need words of wisdom from you, sir. Then we have Mr. Anil Joseph with us, who happens to be the managing director of Abbott India, and he is there at the helm since almost 4 years, since 2016. And it is his efforts that he has seen that API DIAS program goes through with the help of Abbott and in association with API. And time and again, Abbott has helped us in our academic endeavors, whether it is the CMEs and the conferences or this API DIAS program. And this year also, he has seen to it that even if physical conference is not possible across the states of India, then virtual platform has been chosen, and the outreach has probably increased by using this platform. So I welcome you, Anil Joseph, and thank you at the same time for your kind support. So with this, I invite Dr. Arul Raj to deliver his speech, and over to Dr. Arul Raj.
Thank you, Dr. Puneet, for the nice words said about me as well as today's program on API DIAS. And my warm welcome to the chief guest of today's evening, Dr. Vinod Paul. He is a very distinguished member of Niti Aayog. From the medical profession, getting into, the educational services side of the government of India. It's a real great recognition. We really thank our colleague, and we thank him for having accepted to join us in these crucial times. And I join you in welcoming Dr. Hemant Thakur, for accepting to be the moderator. and the two very learned faculties of India, I mean, Dr. Rahul Kulkarni and Dr. Hari Shetty, to discuss about a very key topic today, that is pain. We'll come to it later. First of all, I would like to stress that the API stands for science. API grows science. API supports science. Throughout, that is always the dictum. Though it is a professional body, it always supports science so that the physicians of this great nation are updated online to today's development in the profession. And that is why various CME programs were started. I'm thankful to Abbott for joining hands with API on this API DIAS program right from 2013 itself. In 2013 itself, we have joined and we have reached to nearly about 30,000 physicians of this country. In between, due to few reasons, there were some slackness. Now in 2020, I should thank Abbott for joining us on this digital mode, because all of us are put inside our home, our offices, because of our COVID. Instead of sitting idle and seeing some videos and reading some books and getting sleep and getting a lot of food and becoming obese and encourage non-communicable disease, I thought how to, upscale or continue to upscale our knowledge. The outcome is a digital outreach. Today, thanks to our Honorable Prime Minister, who is dreaming a digital, India, and who is making it. And today, our decision is it is a digital healthcare. Always digital healthcare, as Shashank used to say, has two components. One is a digital medicine or digital learning. That is what you hear, you learn. And then is a digital healthcare. What you see, you offer and adopt. That is digital healthcare. Therefore, we thought, why not we go to digitalization of the scientific program, which we are all seeing today. As Puneet said, digitalization does not have any boundaries. We started with India. Now we have gone to entire Southeast Asia. I'm sure before we close the proposed 30 programs before 31st of December, we'll be whole world. We'll be global. We all wish that we'll become global. Now coming to today's program, it's an excellent program of pain. Hippocrates says, whether a doctor cures a disease, prevents a disease, or controls a disease, has to give definitely relief from pain to a patient. There are various causes and factors, systems for, the pathways for pain, which we will discuss about it, and how to give a relief. And that is also being discussed. It has become a neuropsychiatric problem. That is how I used to say that. That is why we have an eminent neurologist and an eminent psychiatrist. And psychiatry is always a specialty which, our clinicians poorly understand. Maybe the presentation is also a little complicated. I should thank Dr. Shetty for putting it in a way, that even an ordinary junior physician or even a GP is able to understand. I am a strong lover of his presentations in media every day along with Shashank. Today he is with us to discuss about the pain, the chronic pain, how it leads to depression, how to handle it. I am sure all the nearly more than 6,000 delegates have registered. It will come up. All the delegates of today's API DIAS will be greatly benefited by this digital outreach program, and I wish that all of us also get learned. Thank you very much. Thank you very much.
Thank you, sir, for your nice words of encouragement, and API is growing continuously under you. And now we have a second eminent guest who is not present with us, Dr. Shashank Joshi, Padam Shri Dr. Shashank Joshi, who was API president and is currently Dean of Indian College of Physicians. But I request Console to play his video message because some personal reason he could not join. So please play his video message to all of us.
You see, it gives me a great pleasure that the academic wing of API is the Indian College of Physicians, and Dr. Arul Raj has taken and continued this API DIAS program, which used to be a physical program, which used to go to almost 80, 90 cities, towns, and parts of India to do skill building, capacity building. He has converted this whole knowledge dissemination exercise into a digital platform. The two main thirst areas which I want to talk is, one is the telehealth and telemedicine, which he very nicely said that today is the era to adapt and learn skills. We need to use technology right up to artificial intelligence in its best way. And second key is the patient to physician communication also is going to use the same telemedium. And therefore today the key is, the word is the tele. But at the same time, we should not get digitally intoxicated. And I always say in all my programs that you should do a 2 hour digital detox every day. At the onset, I really congratulate Dr. Arul Raj for wonderfully crafting this program, and my very close brother, Dr. Mangesh Tivaskar, very astute Secretary General of Association of Physicians of India, with the help of our team Abbott. Let me tell you something about Team Abbott. They have virtually had no influence on this program. This is a completely unrestricted grant from them, and they have allowed us to take topics which are useful for the practicing physician and the clinicians, so that they can not only learn, but whatever they learn, they can adapt it into their day-to-day practices. And that is so critical and vital in today's times. Also, what is useful is that we need to recognize that healthcare is soon going to get digital, and it is going to become a interactive digital platform, and which is what we are using today. And that is something which is very, very pertinent in the today's era. We also would like to make an effort to capture your feedback and translate it. But the whole aim, as Dr. Arul Raj very nicely said, is that we need to ensure that what you listen, you learn, what you learn, you adapt. And I hope that the various pearls of wisdom in different domains of medicine, which will be spanned over this year, you will learn digitally. And actually, this outreach, which Dr. Arul Raj said, is actually going to reach out to many more people. I was the second president to continue this API DIAS program, but we could reach a finite number. But now with digital health, we can not only reach within India, but outside India. And I would request everyone to make this program into a larger domain so that more and more people can listen, learn, and adapt.
Thank you, Dr. Shashank, and a very dynamic Dean. He is always academically involved, and right now he is the member of Task Force for COVID at Mumbai also, and Maharashtra government is advisor to Maharashtra government for the same. So now I invite today's chief guest, eminent personality, Dr. Vinod Paul, member Niti Aayog, to kindly address us with his words of wisdom.
Thank you very much. Good evening, respected President of API, distinguished leadership of API and colleagues, and also a very special word of appreciation for the viewers and the registered delegates of this event. First and foremost, thank you so much for the opportunity to be able to reach out to a large number of our brother physicians and sister physicians. It is an opportunity for us to connect in difficult times on behalf of the government. I'm pleased to appreciate the initiatives that you are taking in advancing knowledge, advancing fraternal ethos, and advancing the reach of digital health in the country. I would like to make 3 points or 3 themes in the brief presentation, brief discussion that I like to trigger. First and foremost, I would like to salute the contribution of our physician fraternity and health professional fraternity, including our nurses, including our paramedic workers, including the staffs of all hospitals and facilities and public health enterprise, who are fighting the battle of COVID with grit, with commitment, and with exemplary devotion to our nation. I salute all of them, and I particularly salute the ones who suffered during this pandemic, and even more so those who lost their lives. My condolences to the families of doctor colleagues, nursing colleagues who lost their lives due to COVID in this battle. And my heart goes out to their colleagues, their friends, and their children and their families for the great contribution they have made. These are tough times. These are absolutely tough times. This is not uh, only India, this is not only our fraternity, but the entire world, all sections of the world, all stakeholders, all people of the world are suffering because of this unforeseen uh, and totally uh, devastating pandemic that we are going through. To lose 1 million lives across this planet and to lose close to a lakh of lives in our great nation is really a tragedy. At the same time, the country has shown resilience, country has shown capability in stemming the tide of this pandemic, and we will continue to battle all of us together. And whatever we have done so far, given the size and complexity and heterogeneity of our nation, is commendable. We have been successful in keeping the pandemic in reasonable check, notwithstanding the large number. That is the nature of the virus. The virus loves people. But keeping the pandemic rates below the threshold of what health system can tackle is a very important achievement. We on some days have breached our capacities at times in Mumbai, in Delhi, in other cities, Ahmedabad, Chennai, I guess. But we bounced back. We bounced back. And by and large, the consequences of pandemic in terms of morbidity and in terms of clinical care needs have been broadly under control. We also are aware of the fact that the mortality rate, the case fatality rate of the nation in this pandemic is amongst the lowest. And that goes to the credit of not only the administration and the state governments and society at large, but also in particular to the contribution made by health professionals, a contribution made by our health system, a contribution made by public health system and the private health system, and also the leadership, scientific leadership, which has continuously evolved the protocols and learned and built on that to ensure that the care of the second patient is better than the first one. And that has led to considerable control of mortality despite difficult situations. Yes, there are states, there are hospitals, there are districts where mortality rates are not still acceptable. We should help them. We should guide them. We should reach out to those colleagues. Uh, COVID-19 was not known 10 months ago. It wasn't there. We are all learning. And in this battle are not only, the pulmonologists and the anesthetists and the physician, but also other people who normally would not deal with this kind of a disease are converting their system. A nursing home which may be dealing with orthopedics, for example, is now helping control COVID because that's a COVID facility. So they need help, expert help, continuous help, telehealth, EICU, and above all, fraternal feeling and support. And I would urge that as an association, you are playing that role. And I want to emphasize it's not only about the skills and the knowledge that I'm emphasizing, but also the support, the fraternal support, which is so important. We all need to be together in this. Things are not perfect. Things are at times pushed around uh, because of the circumstances by the media, by the people, by the government, by the city government. Uh, uh, but all of those nudges for us are for serving the people. They are all in good faith. And yet, if we are stressed, it is our duty. And it is the duty of an organization like the Association of Physicians of India, which has a great past, more than 75 years old organization, founded by some of the best names in the history of medicine of this great nation. So I would urge you that please do provide that support in addition to the knowledge enablement that we need to do. I want to also emphasize the fact that India's battle is unique compared to other nations because a lot of it is based on Indian technologies. We have devised diagnostics in a matter of weeks. We are now having testing largely by our own enterprise, our own science, our own industry. And tomorrow we are ready for more than one vaccine that would be Indian vaccine, India produced vaccine, India developed vaccine, and that gives us an advantage. And that is the is our responsibility, and that is also our good fortune, because vaccines produced in this country would therefore be more readily accessible to the people of India. But at the same time, these vaccines, treatments, diagnostics are also available for the world. And this is an opportunity for the world to notice us as a country that has enterprise, that has great profession, and great scientists to respond to challenges such as COVID-19. I compliment you as an association for the efforts that you are doing in this regard. My second brief theme is to alert you to the need for enhancing the human resources for health. It is very important that our knowledge and skills are updated. The CMEs are carried out. CMEs are reaching out to thousands and thousands of our people. We are updated. But I want you to understand that the human resource crunch that this nation is facing is very deep, and very profound. And I want your association to think about how you could rise to the occasion in the opportunity that the government of India, under the leadership of the Honorable Prime Minister, is providing. Let me elaborate the point that I'm making. Firstly, we do hope that India would be able to reach allopathic physician to population ratio of 1 or more per thousand by the year 2024. So in terms of general doctors, we should be in a position to have 1 per thousand, the golden ratio that you and I have read in the good old books, that PSN way back. So that 1 per thousand ratio would be achieved by 2024. There has been a rapid increase in the MBBS seats, as you very well know. Since the time Honorable Prime Minister has taken over, there is almost, on 1/3, increase. Dramatic increases have happened. And last year itself, there was an increase of close to 24% seats in one go, in 1 year. Remarkable. We are touching 80,000 UG seats today. When 2014 Prime Minister took over, this number was about 52,000. So that is the kind of escalation that has already happened. And it is very foreseeable that by 2024, the seats would be double of what it was in 2014. So that will make sure that we have the availability of doctors, the production of the doctors to the tune of 1 per thousand. Deployment is another one. Distribution is another issue. And we can talk about that some other day. That remains an issue. It doesn't mean everybody is equally distributed, surely. But definitely, there is a pipeline which is dramatically much better than what we have. However, there is a fundamental problem with the adequacy of specialists. And if I bring to your attention the data, it is very, very disturbing. Let me talk about physicians. You represent the API is about physicians. So in the current ratio of physicians per lakh population is about 3.8. I believe it should be about 12 to 50. because we are the first line physicians. In the absence of a formal cadre of family physicians, we are the family physicians. And that ratio should be 4 times to 5 times. That is a deficit. And I like to ask you and your leadership, what are we doing to mitigate that gap? What is it that we can do together to mitigate that gap? If I look at what is the pipeline, then my numbers are about 4,000 MDMS seats and about 600 DNB FNB seats. So this is about 4,500. Let's say 5,000. Let's say 5,000 because it would rise this year also. Now, if you work with 5,000 pipeline, it would take about 25 years for us to reach the ratio that I talked about. That means the year 2045. I want you to think why and how we can shorten this time period to 5 to 8 years. Think about it. Otherwise, people of India have no access to specialists. An MBBS doctor is today, and you know it better than me, is not a fully loaded family physician. He is not. He might have been when Dr. Jeevraj Mehta established API way back. Today, things are more complex. To be able to be a good family physician in the UK, it is 11 years course, 6 years of MBBS and 5 years of GP. In the US, it is another 12 years course. So definitely you need more grinding. I'm not equating MD physician with family physician, but I'm saying there's a space for family physician where overarching medical conditions are looked after in the outpatient basis as well as in the first level non-specialty or general specialty care. So if I'm saying in that space, this at today's pipeline will take us 20 years, 25 years. India cannot wait. So we must think about how this is to be corrected. And I must say that yes, there is a lot that can be done. But above all, you should be champions of this. I was chairman of the Board of Governors, Medical Council of India. I didn't get a single representation from you all how to enhance physician strength in the country. We need to work together on this. How do we increase the first line of physicians, both in the public and the private sector? So my plea to you is that we need to think cardiologists, because one of our colleagues is cardiologist. For us to be ready with enough cardiologists, we will take 28 years to get a ratio of 2 per lakh from the current ratio of 0.5, because good countries have 2 cardiologists per lakh. Our country is a great country. It has a strong tradition of highly competent physicians and surgeons with the world respects. We want to be in the top 3 nations of the world, if not the very best. That is our ambition. So in that regard, that cannot only be the best roads and the best ports and best railways. It has to be best doctors and the best hospitals and the best healthcare system and so on. So I wish to challenge you for thinking through these things, because API is an overarching body of a great past and a great present. Let me just say what you can do. Firstly, you may have known that we have brought in several reforms, including huge increase in seats, and the PG seats are a record increase. I don't want to go into those numbers. Highest number of medical colleges, 38 in 1 year, some 4,000 PG seats and 20,000 UG seats that are. Everything is a record in Prime Minister's time. But there is much more that needs to be done. And here, my request is that you should actively encourage that wherever you are, please think how you can also be a PG trainer. So you have 2 pathways. Either you are part of a medical college through the National Medical Commission, which has taken over 2 days ago, and we are very pleased to have passed the baton to them. That's one possibility. But more interesting and a fascinating possibility is that you should contribute to DNB courses. I want you, each one of you, to ask, if you have a nursing home, if you are working in a hospital, are you doing DNB courses to the best of your ability? Because every bed that we have in this nation, and there are 6 lakh beds in the private sector, they must be used for education, postgraduate education, general physician education, MD equivalent, DNB, general medicine, internal medicine, whatever you call it. Every bed, because 6 lakh beds are in the private sector. The other 6 lakh beds are producing 38,000 or 42,000, if you include the DNBs coming from that side, 40 to 41,000 PGs. And the remaining 6 lakhs are just giving us 4,000 DNB. What is this? Every bed of India has to be used, and only then can this period of 28 years and 30 years that I'm talking about can be short. I'll tell you how it would work. We looked at Coal India of all railways, let's say railways. And we said, okay, what is the strength of doctors you have and the PGs you have and the beds that you have? And then we said, equal to that, how many DNB seats would you have if you were to be making available DNB seats? You know what the number was? 300 DNB seats every year, over and above what they were already doing. Apollo system, I'm naming it, but Apollo has been kind to be connected in these discussions. Let's say, hey, contribute 300 seats today, 500. But with their network, they have a capacity for 2,000, 2,500. Please think, what you need for a DNB program is a senior physician with 7 or 8 years and a junior physician for 3 or 5 years experience, and you can have 2 candidates. And you train them, because postgraduate education is apprenticeship. It's all by doing and learning. So I want you to keep in mind your responsibility to train physicians. It is not for others only to do it. There is a system that the government of India has created. It's a well-functional system. It is a respected system. I want you to think about it. I want API to see how your members systematically look at what your members can do and guide them to set up DNB and FNB programs. And tell us how we can help you in that regard. Because once you take candidates DNB, your own care also improves because you get more hands to do it. So it's a win-win situation, and I want you to think about it. And if there are any initiatives that you have taken, I'll be very happy to learn about them and see how we can build on them. And I'm sure you are doing several good things about it, and it will be a pleasure to know more about it and to tell others about this. I want all of you to please use your every bed of your inpatient facility and outpatient for specialties like dermatology, laboratories such as microbiology and pathology to train others. India has we have what we have is only 20% of generally what the specialists are required for our nation. The deficits for specialists in general, if I look at my data, is 80%. We can never go wrong. For the next 20 years, we can continue to train, and then as the healthcare would improve, the demand would increase in the world, India could be an exporter, actual exporter, having met the needs of the Indian people. Right now, those who go out are a loss to this nation. We want them here. And API should also have a program to get them back, because this country needs to fill the posts of, of course, in the private care, but also we have so much of faculty shortage in the country. New AIMSs have difficulty in getting faculty. Medical colleges don't have medical faculty. So all your smart people who are listening and who are abroad, please come back to India. All of you are passing in recent times. You should join academics to become medical teachers. Don't shy away. This is our responsibility. Who will teach? The reason why in the Medical Council of India, which I have witnessed for 2 years, college after college becomes difficult for them to be extended their recognition is because they don't have faculty. And you have 19,000 odd members. Please switch over to teaching jobs. Think about it. how are we going to build a robust healthcare system in the country? I'll leave the point there, but I just also want to highlight one or two reforms that we did for you to now lighten the mood. One, of course, you may know that we have introduced a district residency program. So all postgraduates in the second year of their training, whether it is dermatology, pediatrics, orthopedics, physician, medicine, psychiatry, forensic medicine, will go to the district hospitals and work there for 3 years, 3 months, 90 days, they'll work there. So this is an opportunity for them to learn in the real life situation, learn the problems, and listen to the people with whom we are going to serve. Learn from them. Work as team of the district specialists who are there at least, fighting the battle of healthcare in the trenches, so to say, and be respectful to them and learn from them. And above all, at the same time, in addition to contextual learning, which is a high principle of our training, and that is why we should be trained in contexts where we want to work eventually. But the second part would be that this will make available how surgeon level specialist residents who have received at least 1 year and 1.5 years of training to strengthen the services of the district hospitals. So they will strengthen the outpatient. They are available to do outpatient. They will do surgeries in partnership with the local specialists there. And if they are preventive and social medicine, they'll contribute to the National Health Mission. And if they are forensic, they will do postpartum. If they are laboratory people, they'll strengthen the laboratory. And if you look at the numbers game, you would realize that after about 2 to 3 years of maturation of this program, at any given time in every district hospital, there will be 4 to 8 additional specialist residents available, strengthening the services. So suddenly, perhaps the contingent of the specialist teams there would be double or 1.5 to 2 times. So this is one reform we did. There are others where we have made emergency departments essential for medical colleges so that our trauma and accident services improve. We also have introduced for all postgraduates online course to be attended for research methodology. I don't want to go into the detail, but something that you might be interested in. All postgraduates will not be appearing an exam unless they finish and get a certificate for research methodology course from the system, which is the ICMR National Institute of Epidemiology course online. And by the way, that is also essential for the faculty now. They will not get their promotion after 2022 if they have not attended this course. So we're giving a fillip of improved quality of faculty capabilities. Last point that I like to make is in regard to the telemedicine. You may be aware that it is only this March that telemedicine guidelines were released, developed by us, and were notified. This has provided a framework for telemedicine to be legally applicable. There was ambiguity about what the legal position of telemedicine is, and there have been some court rulings which indicated that you cannot prescribe anything through tele system. So this has been taken care of, as you know, and now it is a regulation. It is an enabling regulation which allows physicians like you and me to use the tele route, the media for interaction with my patients, but it is based on a fundamental basis of this is the doctor-patient relationship. That is the paradigm we have embraced in the telemedicine guide. It is not a replacement of face-to-face consultation. It is an adjunct to face-to-face consultation. It builds on face-to-face consultations. It builds on the trust between the doctor and the patient. It is not building the fabric, not breaking the fabric. In fact, strengthening the fabric further, because we have now a mechanism where you can be connected with the patient legally and maintaining the same ethics and so on. Why I need to mention to this is that there will be threats for telemedicine because the outfits may just try to take over, obviating and removing physicians from this system. So be alert to the fact that telemedicine is a tool for our profession. telemedicine should not become should not be, replacing the profession or minimizing the role of the profession and minimizing the role and the connect of doctor and patient, doctor and family, and built on trust and high ethics that our profession represents. So my plea to you is that kindly use telemedicine to benefit your patients. Follow the guidelines, follow the principles behind the guidelines, which are the same that you and I follow in our life in any case. There's nothing very different. It's about transparency, it is about trust, it is about privacy, it is about ethics, it is about confidentiality. And then you're using a mechanism to do things in good faith. But the telemedicine is evolving in our country. It is somewhat new now that it is formal. It was always there. We were always being consulted on telephone. But I want you to think about how to refine this model, how to build on the existing, and how to use it to ensure that our profession is strengthened, our profession gets more respect, and making sure that our profession is not replaced by technology. With these words, my gratitude to you for the opportunity, and your topic on pain is extremely valuable, extremely important, and you have learned speakers who would be now educating you. Thank you so much for the opportunity for me to reach out to you. Thank you.
Thank you very much, sir, for your highlighting the health scenario of India and what physicians need to do. And as a medical fraternity, we need to put our efforts for care of the present situation and to develop physicians for the future and the specialists for the future. Now, I invite Anil Joseph to address us and say a few words, and please stick to the time. And then we'll switch to CMA direct. Anil Joseph.
Thank you very much. It is a pleasure to be here, and as I mentioned, it's always great for us to be, to have these kind of platforms where we encourage sharing and dissemination of knowledge. So again, it's definitely a pleasure to be here. If you can move to the next slide, I'll start and tell you a little bit about Abbott and what we do. So Abbott is a global healthcare leader and that helps people live life to the fullest at all stages of life. We have more than 100,000 people employed across the world, and we've been in business for more than 130 years. It's interesting to note that Abbott is one of just 52 companies from the original Fortune 500 and just 59 from the initial S&P 500 that still remains on those lists today. We serve people in more than 160 countries with a portfolio of life-changing technologies that spans the spectrum of healthcare. We have leading businesses and products in medical devices, diagnostics, nutritionals, and branded generic medicines in emerging markets, generating sales in excess of $30 million. The next slide, please. Our fundamental goal, as I mentioned, is to help people live fuller, healthier lives, maximizing their potential at all ages and stages of life. Our medical devices use advanced technologies to keep hearts and arteries healthy, to treat chronic pain and movement disorders, and to give people with diabetes better insights, more freedom, and less pain. Our nutrition products build and maintain your health from infancy onwards. Our diagnostics provide information to guide effective treatment decisions, and our branded generic medicines help people in emerging markets to become and stay healthy. The next slide, please. And we have market-leading positions in every one of these businesses. We're number one in remote heart failure monitoring, in stents, transcatheter mitral valve repair, heart pumps, continuous glucose monitoring, chronic pain devices, point-of-care testing, blood and plasma screening, adult nutrition, and in medicines in various therapy. The next slide, please. In the medical devices, we're a world leader with a broad portfolio of advanced technologies. For years, our medical device businesses have offered technologies that are faster, more effective, and less invasive. Today, we're focusing on personal technologies that empower people with the data and knowledge they need to help them live longer and better. Our connected care and digital health tools, from mobile platforms to wireless implants to wearable sensors, are helping people and their doctors make faster and better informed decisions about their health in ways that easily fit into their lives. The next slide, please. In diabetes care, Abbott's focus is to provide accurate results faster to more people and with greater convenience, so people who have to monitor their glucose levels can do so with minimal pain or disruption. We are the world leader in continuous glucose monitoring. Our next generation sensing technology, the Freestyle Libre system, is a life-changing innovation that offers elimination of routine finger sticks to draw blood, actionable insights and improved outcomes, a more affordable option compared with other continuous glucose monitors available today. Freestyle Libre users can get a glucose reading plus record the trends in their levels by just swiping an app-enabled smartphone over the Libre sensor, and is now available in nearly 50 countries and reimbursed in more than 30. The next slide, please. We're committed to bringing the benefits of our trusted medicines to more people in the world's fastest growing countries. We offer a broad portfolio of high-quality branded generic medicines across multiple therapeutic areas: gastroenterology, women's health, cardiometabolic, pain management, and CNS, respiratory are just some of them. This diverse portfolio includes the world's leading medicines for pancreatic enzyme deficiency, progesterone hormone therapy, and vertigo. The next slide. Patients and healthcare providers tools, tips, and resources to better manage people's health. We offer market-specific portfolios that supports our localized research requirements. The next slide. We've pioneered innovative ways to screen, diagnose, and monitor a vast range of health conditions with greater speed, accuracy, and efficiency. And if you could move to the next slide. As a result, we are now a leader in immunoassay diagnostics, blood screening, bedside testing, and companion diagnostics. We are a market leader in tests and instrument systems for hospital, labs, and blood banks. Our blood screening systems and tests are used to safeguard almost 60% of the world's blood and plasma supply. Molecular instruments and tests to realize the promise of personalized medicine for managing infectious diseases. Patient-side blood testing for lab quality tests results given in minutes. And sophisticated information solutions that efficiently share information across the health system. On the next slide. Abbott has been named by Fortune magazine as one of America's most admired companies every year since 1984, and ranked the #1 company in our industry for the past 7 years. This is something we're very proud of. This honor is a result of the excellence across our company. We've been ranked as the industry group leader on the prestigious Dow Jones Sustainability Indexes for the 7th consecutive year. It's the 15th year in a row that we've been named to the index. We were named to Fortune's magazine's list of best big companies to work for in 2020. We've been named one of the best places to work in more than 25 countries. And Working Mother magazine has selected Abbott as one of the top family-friendly workplaces in the US for 19 consecutive years. The next slide. I just want to close by mentioning that we've been helping people live life to the fullest for more than 130 years. We value the achievement and perseverance it takes to accomplish challenging goals. That mindset is reflected in our sponsorship of the Abbott World Marathon Majors, and it's evident in the way that Abbott people approach the important work we do. We're very proud of our long history of successes, but we're constantly looking to the future, seeking new and better ways to help people live their best and fullest lives. We're strong, we're focused, and we're ready for the future. With that, I wanted to thank everyone again for participating in this wonderful program, and hope that you all gain a lot of knowledge from this program. Thank you very much.
Thank you, Anil, for telling us that what good work Abbott is doing, not only in India but globally also. And it was nice to know that it is one of the most admired companies and a nice place to work on for the employees also. And we thank you for your continuous supporting the API forum and supporting the academic cause. So we now move on to our main program for today, that is the scientific program. And the session for today is when treating pain becomes a headache for clinicians. And for that, I want to invite Dr. Hemant Thakkar, who hails from Mumbai and who is an eminent physician. And not only physician, he has a special interest in cardiometabolic disorders, and he is basically advisor to Bennett and Coleman and for Mondial Insurance, and he has been an invited faculty on national and international platforms and has been principal investigator in as many as 35 trials. And he's a very good speaker basically and orator, and he will be moderating the session for today, and he'll carry the things forward. So over to Dr. Thakkar, please.
So good evening, everybody. I think today's topic is mainly related to pain and the headaches that emanate from it. So I'll come to the key points today. We've heard enough about telemedicine and the good points of telemedicine. But the crux of today's thing is to look into the fact that everything finally in medicine boils down to a supratentorial etiology. And what better evidence do we have than COVID, where we find patients who are sick have anxiety of the disease. The patients who are not sick but are sitting at home have anxiety that they will get the disease. And those who are getting cured and going home or who have got cured at home have the anxiety that they will get reinfected. And we are busy with our teleconsultations, and the 30 or 40% of the questions are rooted around this. Will I get it? If I get it, what will happen? Can I get it again? There are people who are getting breathless. There are people who are seeing their temperatures all in the mind. The breathlessness is in the mind. The temperature is in the mind. Everything is in the mind. So I think for today's API DIAS, when somebody said that when treating pain becomes a headache for clinicians, I can clearly understand, because when treating COVID, it becomes 40% psychiatric and 60% infective physicians. Let's have the next slide, please. Remember, when it comes to pain, 20% of the adult Indian population suffers from chronic pain. The pain could be in the joints, the pain could be in the back, in the limbs, abdomen, chest, anywhere. But 20% of Indian adult population suffers from chronic pain. Next slide, please. Now, in treating this chronic pain, remember, immediately the mind gets affected. And in a study of psychiatric comorbidity among new daily persistent headache patients, remember, persistent headache patients, psychiatric comorbidity, severe anxiety was seen in about 2/3 of them, and severe depressive symptoms were seen in 40% of such patients. Next slide, please. So remember, there is a very close link from the headache owing to the pain and the depression and the anxiety, so much so that the masked study clearly showed that migraine was about 3 times more likely to report a medical diagnosis of insomnia, depression, anxiety, which means all those pundits who are treating migraine with MRIs of the brain and CTs of the neck and ophthalmic discomforts. Migraine's common etiology is insomnia, depression, and anxiety. I'm not saying that it's the masked study, which is Migraine in America Symptoms and Treatment Study, which is extremely important to allude to. Next slide, please. Again, reminding you that 85% of patients with chronic pain are thus affected by depression. Like I say, that today 50% of breathless patients are depressed sitting at home in the lockdown. They do not have breathlessness because of COVID, they have breathlessness because of depression. So the next slide, please. 85% of patients with chronic pain have depression. What about anxiety? Almost two-thirds of patients of chronic pain, if they don't have depression, they have either depression and also anxiety, but two-thirds of them have anxiety disorders. And again, this is very evident when we treat our day-to-day patients, especially in these trying times of COVID. And the teleconsultation is ample proof for all this. Next slide, please. So remember, 67 to 88% of persons with chronic pain have sleep-related complaints. And we all know that patients in pain do not sleep, and patients who do not sleep have more pain at night because everything else is removed from their mind. External stimuli are dissipated. So it's the relationship between the chronic pain and the mind. Next slide, please. Next slide, please. So this is a vicious cycle. Chronic pain at 6 o'clock takes you to anxiety at 9 o'clock, depression at 12, sleep disturbance at 3, and this vicious cycle can go clockwise or anti-clockwise. But this chronic pain, depression, anxiety, sleep disturbance cycle, this is the crux. And if we can treat this, most of the symptoms, not only of pain as a physician, and the number of times 2.5 or 3 decades ago, when patients had gas in the chest, they ran for an EKG. When they had burping in the left side of the chest, they ran to the EKG. So the number of times the mind has ruled over the body is completely proof of this cycle. Next slide, please. So let's see, how do we look at this pain management? And you need a multimodal pain management. The new kids or the kids on the block that are showing good results are the tricyclic antidepressants. They are the most studied antidepressants for the treatment of chronic pain. And today, for the wise physicians, they are the mainstay in the treatment armamentarium. The pain relief with TCAs appears to be independent of the antidepressant effects of these drugs. So you don't have to give them in the antidepressant doses. So your patient needs to be told, I am not treating you for depression, because the pain relief may be achieved at doses lower than those used in the treatment of depression. The biggest enemy, not only of doctors, but also of patients, is Dr. Google and Mr. WhatsApp. So this Dr. Google and Mr. WhatsApp takes the wind out of the sails of most good prescriptions, because they tell you, साहब हमने वो गोली तो नहीं लिया क्योंकि वो डिप्रेशन की गोली है. So patients given TCAs can also expect to take fewer doses of analgesics. as many as 16 to 18 doses per month. Remember, the side effects of analgesics, NSAIDs, are so many. Forget the gastric acidity and the ulcers. What about the renal dysfunction and so many other things? So, if you can use pain sparing medication in non depressant doses, TCAs are the way to go because they are superior to SSRIs, and this has been seen in several trials. Next slide, please. Remember, when I talked about trials and studies, it is the Donovan study almost 3 decades ago, where dotiapine was studied against amitriptyline for depression on analysis of comparative studies, and dozulupin had an efficacy similar to amitriptyline, but was better tolerated as compared to amitriptyline. And it is this Donovan study which is quoted repeatedly. Next slide, please. With this, I think I do not want to be between you and the two eminent faculties. Remember, pain at the center, a neurologist on one side, a psychiatrist on the other. It's going to be a dog fight, but finally, the cat and the dog will be together and the patient will benefit. I don't want to take up my time. That's over. I would like to have the session open. And if the organizers permit, I would like to invite Dr. Kulkarni. Is that your sequence of events?
Yes, doctor, that's the sequence of events.
So let's have Dr. Kulkarni's introductory slide while you get his correspondents all in place. I want to now introduce and lead the game by having Dr. Kulkarni, our neurologist, to kick off first on today's topic. Do I have an introductory slide of Dr. Kulkarni coming up? I am happy to only say that he is an eminent neurologist, which really he is. And I don't think I'm going to, we've spent enough time doing other things which were not related. So Dr. Kulkarni, your slides and you will speak for your prowess and your achievements. Dr. Kulkarni, the stage is yours.
Thank you. Thank you, Chairperson. And thank you, API, for this kind of meeting. You know, indeed, pain is an important topic, and I'm happy that API have arranged a meeting on pain, which is a fairly important topic for all of us. Can I have my slides? Okay, so I'll be talking about when the treating of when treating pain, it becomes headache for the clinician. So obviously, I'm not going to talk about headache, but I'm going to talk about those pains which are really difficult to treat, and then they are becoming headache for a treating doctor. Can I have the next slide? Next slide. Yeah. So we know that pain is, by and large, the most common symptoms encountered in the practice by everyone, right from the general practitioner to the consultant to the super specialist. And it forms about 40% of total patient going to a doctor, may it be a neurologist, may it be a gastroenterologist, may it be a dermatologist, may it be a psychiatrist, of course, for physician as well as general practitioners. And pain medications have been commonly prescribed drugs by all sorts of specialties. Still, there is an unmet need about treatment of pain. Can I have the next slide? So the definition of pain says that it is an unpleasant sensory as well as emotional experience which is associated with actual or potential tissue damage or described in terms of such damage. This is a definition given by International Society Against Pain. So this is a definition which has two important words into this. Next. That pain has an emotional component. It is not just a sensory phenomenon. There is an emotional component. So there is a strong emotional component into it. You are in distress, you are in stress, you are in depression. The pain may be felt more severely. So there is a strong emotional component to it. And next. And then pain can be experienced even when there is no actual tissue damage. So, you know, you can get pain when there is no tissue damage. So it is sometimes difficult for the patient to explain that why he's getting pain when you say that CT scan is normal, the MRI is normal, still your head is paining. there is no actual tissue damage seen, but still you get pain. So pain can be seen even when there is no tissue damage. Next slide. So there are various types of pains. Pain can be classified in various ways. One way is to classify it as neuropathic versus nociceptive pain. Another way is to say chronic versus acute pain. Then we can have somatic versus visceral pain, and organic versus psychogenic pain. Of course, no one uses the psychogenic pain word anymore, but then there are various ways in which pain has been classified. Next slide. The most important classification to differentiate between two types of pain, the nociceptive pain and the neuropathic pain. Nociceptive pain is a pain which comes when there is activation of this peripheral nociceptive receptors. So you get a local pain, you get a local injury, the local nociceptive receptors are stimulated and a lot of neurotransmitters are released there, and then the pain is felt. While neuropathic pain is a pain which occurs because of lesion anywhere along the somatosensory system. The lesion can be in the peripheral nerve, lesion can be in the spinal cord, or lesions even can be in thalamus. So this is a pain which is because of damage to the somatosensory pathways. A local pain, of course, will occur at local site. It can be referred pain also if it is a visceral kind of pain, while the neuropathic pain would occur in the area of innervation of the nerve, or probably in the area of the spinal cord, or even in the area of the brain where the pain is felt. The nociceptive pain is usually the ordinary painful sensation that we all know. But in neuropathic pain, patient get all sorts of pain, and the type of description that they give are all funny: burning, aching, tingling, pricking, all sorts of different words that you use, squeezing, all sorts of words are used by patients to describe this neuropathic pain. Next slide. So nociceptive pain, as I said, would occur because of local release of various agents like prostaglandins, bradykinin, serotonin, adenosine, and cytokine. This is a pain. Important to know that this is a pain which responds to NSAIDs. Next slide. While neuropathic pain is a pain which does not respond to NSAIDs, this is a very important point to differentiate between two pains. So if patient has a neuropathic pain and you keep pumping NSAIDs, the pain is not going to get relieved. These patients require different medicines. And one of the medicine, of course, as Dr. Thakkar said, is TCS. There are other medicines which also can be used. The neuropathic pain typically would occur if the lesion starts along the nerve, or along the spinal cord, or along the brain, somewhere in the area. Next. So there are these kind of pains that post-operative pain, mechanical low back pain, arthritis-related pain, sports injuries, exercise injuries are all nociceptive pains. Neuropathic pain typically are trigeminal neuralgias, peripheral neuropathies, post-herpetic neuralgias, central post-stroke pain, etc. And then there are mixed type of pains like back pain, which initially may start as a nociceptive pain, but later it becomes a mixed kind of pain, which when there is a neuropathic component which also adds up into this. I'll talk about this little later also. Next slide. And there are these other types of pains which have been described, which are not classically been part of nociceptive or neuropathic pain. These are the pains where pain would arise because of neurological dysfunction, and there is no damage to the nervous system, but there is a dysfunction of the nervous system. And the commonest example is a disease which is called as fibromyalgia. Many of us think that this disease does not exist. There are many people who say that this is one of the most common diseases. Many of these patients are seen by psychiatrists, rheumatologists, neurologists, pain specialists, and many doctors. So these kind of pains are called as other kind of pain, and there have been other names given for this kind of pain. You can see that some of the names are algopathic pain or nociplastic pain, etc. But then this is a different kind of pain, and there are patients who can have combinations of this pain, and those who have combination are really in hell, because these are the very difficult pain to manage. Next slide. The other way to classify the pain is to differentiate between acute pain and chronic pain. Acute pain usually would start after an injury occurs, and the pain would resolve or disappear when the injury heals or the tissue heals. While the chronic pain is usually insidious in onset, and the pain would persist even when the tissue is held. Acute pain usually is the warning sign of actual tissue damage. So acute pain is a good pain. It suggests that there is a damage which is happening. One has to look for the damage. But in chronic pain, it is a false alarm. There is no warning signal because of damage. Many times there is no damage seen at all. Acute pain usually would go hand in hand with the amount of, the severity will be hand in hand with the amount of tissue damage. While in chronic pain, the severity may not match with the tissue damage. So patient says that I got back pain. He or she comes to us with a back pain happening for 5 years. You do MRI and you hardly see any lesion in this patient. So it may not go hand in hand with the amount of tissue damage seen, especially on images, etc. And the CNS involvement is fairly common in chronic pain. So many of these chronic pain syndromes are actually neuropathic. There are very few chronic pain syndromes which are purely nociceptive. Majority of them are neuropathic. And of course, one can make out that because of this chronic pain, they have significant amount of psychological effects. They have depression, anger, fear, withdrawal, etc. And again, we'll have Dr. Harish Shetty talking about this later. Next slide. Third way is to classify pain between somatic and visceral pain. Pain which happens in musculoskeletal system is a somatic pain, but the patients who get pain, chronic abdominal pain, again a very common symptom seen by our GI friend as well as physician as well as surgeons. Patient undergoes CT scan, various types of scopies, maybe exploratory laparoscopy, etc., and nothing is found. So it's a visceral pain, which is a type of neuropathic pain occurring in the visceral organ. This is a pain which is squeezing, cramping, gnawing, and various names have been given to this kind of syndrome, irritable bowel syndrome and whatnot. It's a poorly localized pain. Often the pain can also be referred to other areas also. And then we can have somatic pain, which is localized kind of pain. So this is the way in which one would classify the pain. First is, of course, to see whether the pain is acute versus chronic, and secondly, to see whether it is nociceptive pain versus neuropathic pain. Nociceptive pain is fairly easy pain to manage. It would probably be managed with the help of analgesics, and if you treat the underlying disease, the pain would disappear. But the chronic pain and the neuropathic pain are the two pains which are difficult pains to manage. Next slide. The mechanism of pain, during the talk I told that it starts from the organ, then the pain fibers carry the pain sensation through the peripheral nerve, through the dorsal root ganglion in the spinal cord. There are ascending pathways which carry this pain up to the level of thalamus, from where it is carried to the brain in the predominantly posterior parietal areas. There are also descending fibers which go along these pathways, and they have some control over these pain fibers. And we know that there is this theory which was called as gate control theory. I am sure all of you must have heard this theory in your college days, and it is along these pathways where we have neurotransmitters acting, and that's where probably the neurotransmitter drugs acting on the neurotransmitter work in the treatment of pain. Next slide. So there are these ascending and descending pathways. As I said, the ascending pathways can be of two types. One of them is a fast pain pathway, and the second one is a slow pain pathway. They go along the spinothalamic tract. One of them is called as neospinothalamic, and second one is called as paleospinothalamic tract. These are the types of pathways which carry the pain. And then there's a descending pathway which goes along the dorsal column, which is an inhibitory pathway, and it inhibits these pain fibers. So if the descending pathway is active, the pain can be perceived lesser in these patients. Next. So as I said, because of lesion or dysfunction along the neural pathways, centrally or peripherally, one can get pain. Next. And then if the disruption occurs, there is hyperexcitability or hypersensitivity of the pain pathways. And then at some point of time, even if there is no tissue injury, the pathway starts firing spontaneously, and then one would get pain which would occur even if there is no tissue injury. Next slide. So which are the difficult pains? Which are the pains which really give headache to the clinicians? It is those neuropathic pains, not the nociceptive pain. It is the chronic pain, not the acute pain. Acute pain, sometimes patient can have a very severe kind of pain, but you know how to treat it. Most of you are champion of treating acute pains, but it is a chronic pain which is really troublesome for us, and probably the visceral pain than the somatic pain. So these are the three difficult pains which really give headache to a clinician when you see patients. Next slide. Why are these difficult? Because the location as well as nature of pain is probably not known properly. You cannot give proper explanation to all pain syndromes in these patients. They may have various mechanisms, heterogeneity in the mechanism is seen. And then, of course, the symptoms may be different. Patient who has a diabetic neuropathic pain, he or she can get different sorts of pain. One patient can get different pain, and many patients will have different kind of pain. Routine analgesics do not work in these patients, and they will have associated comorbidities, and you probably will have to address these comorbidities when you are treating this pain. So not just treating pain, we will have to manage these comorbidities as well. Next slide. So little bit about these two pain syndromes, the chronic pain syndrome as well as the neuropathic pain syndrome. Neuropathic pain syndrome is seen in about 8% of population, more than 20% of chronic pains, more common in females, more common in elderlies. more common in people with lower socioeconomic status, and typically it involves areas in the low back, neck, limb. So someone who get low back pain, neck pain, limb pain or symptoms, tingling in the limbs, usually will have neuropathic pain. And the definition says that it is a pain which initiated or caused by primary lesion or dysfunction along the nervous system. So it's a pain which is because of damage to the nervous structures. Next slide. The clinical picture of neuropathic pain will have various symptoms. There are negative symptoms in the form of numbness or hypoesthesia, but it is the positive symptoms which are really the way in which we diagnose neuropathic pain. The positive symptoms can be spontaneous, which can come as a continuous symptom. So patient can say that I have got burning or tingling which goes on and on all the time, or it can be paroxysmal, that patient says that I get sometimes this pain which comes and goes. So typically like in trigeminal neuralgia. Or the pain can be evoked. You touch the leg, patient gets pain. You touch the face of a patient of trigeminal neuralgia, he or she will get a pain. So these are evoked kind of pains. And they can also have autonomic symptoms. They will have edemas, they can have flushing, they can have pseudomotor changes as well as vasomotor changes. The area may appear reddish, it may be appearing little warm to touch, and there may be some edema also. So this is a typical clinical picture. Of course, all the patient may not have all symptoms, but these are the symptoms that one would get in a patient of neuropathic pain. Next slide. The neuropathic pain can be peripheral or central. In peripheral, it can be asymmetric or it can be symmetric. Asymmetric pains include entrapment syndromes like carpal tunnel syndrome, mononeuropathies, radiculopathies, plexopathies, neuralgic pain like trigeminal neuralgia, post-therapeutic neuralgia, pain after amputation, pain after trauma, which is called as complex regional pain syndrome, or it can be symmetric. The most common example is painful peripheral neuropathies. All physicians are aware of this disease. And then the pain also can occur because of following strokes. Typically, it is seen after thalamic stroke, but it can also be seen after lateral medullary syndrome or other types of strokes. Pain can also occur in patients who have got spinal cord injury, and pain can also occur in people who have got multiple sclerosis. So neuropathic pain can occur because of number of conditions. Next slide. Next slide, please. And as I said, in the mechanism, in this slide, you can see that in the normal physiology, it is the tactile fibers as well as free nerve endings. They carry the fibers, sensations through the spinothalamic tract going up to the level of brain. When there is an acute pain, it is the free nerve endings which are firing, they start firing, and then one would get pain because the free nerve fibers endings are which are sensing the pain are stimulated, that stimulation of the spinothalamic tract, and one gets a pain. But in neuropathic pain, it is next, click, 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 click 3 times. One more. Thank you. So in the chronic pain, no, go back. Please go back. Go back. Yeah. In the chronic pain or in the neuropathic pain, it is the tactile nerve fibers which start firing spontaneously. There is no injury, but still they start firing. There is also spontaneous firing along the spinal cord. And then there is this descending inhibitory fibers which are disinhibited. That's why one would get pain. So these are 3 reasons because of which one would get neuropathic pain. Next slide. Talking about chronic pain, any pain that lasts for more than 3 months, that is 12 weeks, is called as chronic pain. It can occur long after initial cause of injury has been removed. So you get a minor trauma, the trauma is healed, but still patient keeps getting pain. That's a chronic pain. Next slide. And the chronic pain can be primarily nociceptive, typically seen with osteoarthritis, certain visceral pains, many headache disorders, ischemic pain, cancer pain, back pain without any nerve injury. These are the examples of primary nociceptive pain. But many of the pains are primary neuropathic pain, like back pain, neuralgias, peripheral neuropathies, post-stroke pain, etc. And then these syndromes like cancer pain and chronic back pain can also have combinations. So they will have both nociceptive as well as neuropathic component. And then this is a really very, very difficult pain to manage. Next slide. And then there are associated features. Dr. Thakkar told about this. The depression, anxiety, fatigue, insomnia are the common associated factors with these disorders, chronic pains. Next slide. Next slide. And this the correlation or the both these disorders would occur hand in hand. Chronic pain leads to depression, depression leads to chronic pain, and one would lead to other would lead to one. So there is a vicious cycle when patient will have both. Next slide. So depression can cause pain, and pain can also lead to depression. 85% patient with chronic pain will have depression, both brain regions, which lead, as well as neurological functional disorder where chronic pain has would also lead to depression. So fibers or the areas in the brain where pain is perceived will also be involved in will also be involved in depression, and so are the neurotransmitters. Next slide. And patients of chronic pain are not just prone to depression because of the biological mechanism, but because of the burden of the disease also. They would, and if they get depression, they would go to doctors more often. It would lead to more cost of the treatment, and it would lead to more less satisfaction of the patients significantly. Next slide. And with depression, we know that patient will have many symptoms. Depression can have emotional symptoms, but they will also have physical symptoms, and it is those physical symptoms of depression where patient would go to physicians and they won't go to psychiatrists. And headache, neck pain, back pain, abdominal pain, and musculoskeletal pain are very common symptoms of depression per se, and I'm sure Dr. Shetty would agree with me for that. Next slide. So talking about chronic pain, why this disorder of chronic pain develops? Basically, if you have acute pain, there is an injury that leads to inflammation leading to spinal cord activation, and then the pain is perceived. When there is resolution of the pain, when there is healing, the inflammation is reduced, the spinal cord activation is reduced, and then the pain is less. Click next. Please click. Yeah, and there are some patients who from acute pain directly go to this third stage where the injury is healed, but the memory is remaining, and then the spinal cord keeps firing in those patients, and then it leads to the chronic pain. So why in some patient that this from stage 1 they go to stage 3 and disease? You have to manage chronic pain as a disease itself. It is a very important statement. It would require its own treatment. It may be because of diabetic neuropathy, you treat whatever is the cause, but the disease, chronic pain, requires specific treatment. Next slide. And the treatment is difficult. Most of the times the patient visit to a doctor multiple times, or probably multiple doctors at least once, and the satisfaction of the patient is minimum. Next slide. And the treatment options are many. Just click few times. Click once. So the treatment can be physical approaches, topical medicines, systemic medicines. Next. Interventional treatments where pain specialists are the part of it. There are non-pharmacological means. Again, I'm not expert into this. Next slide. And the pharmacological treatment. The pharmacological drugs, the first drug is always antidepressants. TCA are the most important drugs. We can also use SNRIs, anti-epileptic drugs like alpha-2 delta ligands like gabapentin and pregabalin. We use it often. Other anti-epileptics can also be used. Opioids are the other drugs. Topical agents which are never famous in India like capsaicin or lidocaine can be used in some of these patients. And rarely one can use other drugs like clonidine, memantine, mexilentin, etc. And then there are these large number of nutraceuticals which have been famous in India, which have been given in various peripheral neuropathic syndromes, about which evidence is not very high. Next. What about analgesics? Analgesics do not have major role as far as treatment of chronic pain or neuropathic pain is concerned. Long-term use of analgesic or even intermittent analgesics, strictly no. One can use analgesics only on SOS basis, but even this SOS also has got abuse potential, and abuse itself can lead to a different pain. In headache, there is one disorder where patient keeps popping these analgesics on a daily basis or maybe frequent basis, and then they develop this different headache. A migraine patient, he or she develops a different headache, which is called as medication overuse headache. And the treatment of this headache is simple, not very simple, of course, but if they stop this analgesic, the headache reduces by 50%. So overuse of analgesic not only has side effects like GI or nephrotoxicity, but it also causes certain changes in the chemical milieu in the brain to lead to different types of pain disorders. Next. and I'm not going to talk about TCS because we have an expert talking after me. We'll be talking about TCS. So their effect is independent of the effect on depression. Dr. Thakur told us about this. They act on the doses which are peanuts. When we start writing doses of 5 and 10 milligrams, psychiatrists start laughing on us, but many of our patients respond to these doses, and the effect comes earlier within 1 week after this the drugs have been started. Next. And TCS, there is no consensus which is the best TCS. All of them probably are similar. So the choice would be dictated by the adverse effects of the drug. And next slide. And we heard about this trial. Next slide. Where dotiapine or go back. Dosulpin is a drug. Please go back. Is a drug which is efficacy wise similar to amitriptyline because of the trial, but it is tolerated better, lesser side effects, lesser cardiac side effect, lesser lesser anticholinergic side effect. So it is tolerated better. So this is a good alternative as far as treatment of chronic pain or the neuropathic pain syndromes are concerned. Next slide. Next slide. Thank you. I think I'll stop here, and then I'll be happy to take questions later time. Thank you.
So, thank you very much, Dr. Kulkarni. Hello, am I audible?
Absolutely.
I'd like to introduce our speakers once again, and I had requested the organizers to put up the introductory slide. So if somebody can help me with the slides. Right, so Dr. Shetty is our next speaker. And after I introduce him on this slide, I'm going to ask them to also put up, before Dr. Shetty starts, Dr. Kulkarni's slide. Dr. Shetty is a colleague, good friend of mine. He is a consultant psychiatrist. Now, I don't know where the neurologist came in here, but he's a psychiatrist known for his work in community mental health. He has worked with victims of disaster, communal riots, etc., legal interventions, have really helped in conducting workshops with the youth on suicide prevention, and trains that lay people to the mental health. We all wish he could have met Sushant Singh Rajput also 6 months ago. He was extensively working with seafarers rescued from Somalia. And recently, he has been appointed as a member of the National Testing Agency by the Union Cabinet on behalf of the HR Ministry. And he's the president of My Home India, an NGO that helps integrate the rest of India to the 7 sisters and 1 brother, which is the 8 states of Northeast India. Dr. Shetty is a good friend of mine, an excellent psychiatrist, an erudite speaker. And before he takes on the mic, please give me Dr. Rahul Kulkarni's slide also. So I would have done justice in the same vein. Swapnil, I don't want the slip between the cup and the lip to show.
Yes, doctor, just playing. Allow us 10-15 seconds.
All right, so then I'll hand over the mic to Dr. Shetty. I'll again come back to introduce Dr. Kulkarni. Let me not keep you between Dr. Shetty and his interesting talks. Go ahead, Dr. Shetty.
Thank you, Hemant, and thank you, Rahul, for that wonderful presentation. Thank you, FPI, for really inviting me here. And that's what it is. Let me start by saying one important sentence. Physicians should treat depression. Simple depression. We will treat depression associated with suicidal thoughts and suicidal ideations. We will treat depression associated with bipolar disorder or a comorbid condition like drug addiction. We will treat depression associated with post-traumatic stress disorder. But normal depression, a physician should treat. And if at all you have not started treating, pick up 5 patients. Keep in touch with the psychiatrist on the phone and continue giving medications with advice. And once you treat 5 patients across this next 1 year, you'll have more confidence in treating depression on your own. Now, the other day, I saw a patient, chest pain, palpitations, breathlessness, as Dr. Thakkar described. And they said, "Nahi, nothing is wrong with him. You please handle the pain. Other things will manage. We have done her COVID test. Nothing is wrong with her." And nothing is wrong with her is a very common sentence which the lay people utter when somebody has a psychological disorder. That's one sentence no physician should ever utter, even subconsciously or consciously, that destroys the moral of somebody who's depressed. And the pain was there in the chair. She said, "Here," and she would fall down. I kept quiet. I said, "She will be all right." I did not give her any diagnosis. I did not tell the family any diagnosis. I said, "She'll be all right." Now, most of the time when there's pain, aches and pains and pain, it is actually either severe anxiety or severe depression. It's depression trapped in the body. That's one of the most important symptoms of depression. I gave her dosalpine. My favorite drugs for this is dosalpine and amitriptyline. And I did not give her 25 milligram. I started with 50 milligram because, as Dr. Rahul and Dr. Hemant said, pain is associated with insomnia. And when it remains for a long time, it could be depression, or depression could be the causative factor of pain. And she was well within 2 to 3 weeks. Now today is the 8th week and she's much better. And the patient's close relative came and said, "What did you do?" I said, "I treated the pain." And then calmly I explained to them what she could be suffering from. She could be suffering from anxiety of COVID and depression of COVID. And then we put her onto a counselor so that she could be explained and counseled about the risks of COVID and the chances that she would not get COVID if she's at home. Now, what is very important is introducing the right treatment at the right time is the real magic and the expertise of a physician or a psychiatrist. Now, why I have put this slide? I'll tell you why. This is the NCRB figures of suicide in 2019. 15.4% of those who ended their life by suicide in 2019 in India are housewives, and 50% of the women who have committed suicide in India are housewives. So whenever you see a housewife coming to you, be a little gentle, check for depression apart from checking from pain. Next. And as you see this slide again, I still remember this woman, 62-year-old woman, coming and saying that I have got pain in the stomach, I have got cancer. They have been through different doctors, all pathies, including psychiatrists. And she was very upset because the son brought her to me. And I was a psychiatrist. And she said, "I don't want to see a psychiatrist." She said, "If you can treat my pain, I will be happy." But she said, "I've got cancer, I've got pain in the stomach, you have to help me. I don't have any depression." And she was about to get up. I said, "No, psychiatrists also treat pain." And that's what I said. And she calmed down. She was a Malayali patient. And as she sat down, she said, "See, these are the pills I've taken." And there was a lot of SSRIs given to her across time. It did not work. There was no point in telling me and asking her what is wrong. The sister was keen to say that she is very closer to her son. She's not close to me. She's upset because I married somebody else. All those factors don't matter, because if I twist somebody's hand and the hand breaks, taking me to the police station will not resolve the fracture. I kept quiet. I said quietly, I bought time. I said, "You'll take at least 4 to 12 weeks to recover from this. Give me time." She said, "No, I can't wait." I said, 4 to 12 weeks, 2 weeks. And I did not give her a small dose of a tricyclic, as Dr. Rahul said. I gave her a good dose, because sometimes when the pain is severe, when you've been to many people and also have taken small doses of other medications, good to give a good dose, 50 milligram of a tricyclic. Straight. Her ECG was normal. There was no QTC issues at all. And I had told the son that he should sit with her, sleep next to her, as and when she's up from the bed and she goes to the toilet. She responded to the tricyclics after 12 weeks. There was no cancer and there was no pain. And then she sat down and asked me, what exactly happened to me? I said, "The pain you felt here, but the cause was in the main switch. The cause was not in the bulb or in the tube light. You felt the pain in the stomach, but the cause was here." And I corrected that entire cause. I did not tell her that it is depression, because she was very hostile to me when she heard the name of any psychiatric illness. But I'm going to explain to her how did it all happen. Now look at this slide again. 2019 India suicide figures. NCRB, National Crime Research Bureau, 1 out of 3 people who end their lives by suicide is because of family problems. So all physicians should address family health when they treat physical illnesses. Ask them about how's the family health. Ask them about the interpersonal relationships. I know you have no time, but check for depression along with pain, and you might find untreated depression in many cases. So you might save life by treating depression. Next slide. Well, a lot of girls end their life more than boys before the age of 18. And this girl, I still remember, 17, had a breakup, wanted to die, did not die, cut her hands, went to the casualty, refused admission, came home. And then they said, we don't want to get admitted because it's going to be a police case. No longer attempted suicide is a crime, though there's a Supreme Court case still on where the Chief Justice has asked the government, how will you resolve the 309 IPC and the Mental Health Care Act? And the government is supposed to reply, but it's going to be in the favor of the patient. Now, this girl said, मुझे कमर में दुखता है. I have a lot of pain in my back. And all tests were normal. She almost went under the scalpel, but all tests were normal. And her father said, this is a challenge to you, doctor. She will not come back to you again. I first empathized with the breakup. I did not say anything which could make her feel sad. I acknowledged her love. I respected her love as she shared her stories. And then again, I realized that she needs a pill and she needs healing. Both equally important, but the pill to help her sleep and bring down her pain. You can do it. Physicians should do it. And then again, here I started with a small dose because if she oversleeps, she will not come back to me because she has to go to college. And then slowly again, now the counseling is in process and she's much better. Under 18, more girls in India are dying of suicide than boys. And that is a very interesting figure which has come in the last 2 to 3 years. Next slide. Next slide. Yeah. Now, again, a somatic symptom of pain is more common in the North Indians. पेट में साई साई होता है, पूरा शरीर दुखता है, इधर भी दुखता है, यहाँ भी दुखता है. The pain is here, the pain is here, there. I have some sensation in my stomach. I don't know, but pain is also in my back. But very surprisingly, in North India, the rates of suicides are very low. UP, Bihar, very low suicides. Suddenly, you might say that actually, they may be underreporting, but I am not prepared to believe that straight. I would say that there should be a research to find out whether somatization of depression and the pain of depression actually helps decrease the intent and decrease the number of suicides. Is it that there are better support groups among the poor? Is it that the social support system is better? Is it that the cultural base is better? And I would like to explain to you also that among people who attempt suicide or die of suicide in NSRB figures, 72% are those who are uneducated or educated up to the 10th standard. So again, this figure is very different, but still the somatization symptom and the pain symptom is very common from patients who are coming from the north. Next. So depression is a heterogeneous disorder. Headaches, stomach aches, pain, psychomotor agitation. Now, children come with a lot of headache. Ophthalmic examination done, neurological examination done. Porphyra checked because of stomach ache if he has or she has, and this pain. And this pain is largely because of anxiety. Most of the time, the pain is because of academic issues, but very rarely it could be issues like child sexual abuse, trauma at home, and so many other reasons. If all psychological therapies does not relieve this pain of a child under the age of 18, tricyclic is much better than giving SSRIs, though in depression among children, we give SSRIs, fluoxetine being the drug of choice, escitalopram and sertraline being the other two drugs. But when there's pain, and after all the psychological therapies, I would prefer giving a tricyclic. Here, I would agree with Rahul a very small dose, and that works. Now, if the pain is associated with depression, and if you do a PHQ, patient health questionnaire 9, and you find that the score is above 14, above 15, or above 19 and in 20, then you have to give an antidepressant dose for the patient. Next. Well, as we all see that depression is increasing in India, it's not because the brain has changed its size, shape, volume, neurochemistry, textures, because the world is changing around us. And when stress is not treated early, when the person is in chronic stress, it ends in depression. So it's very important to understand that you need to treat stress and burnout very early. Now, what are the symptoms of stress? Again, office, I went to office, but my boss said my salary is cut by 30%, and I don't feel comfortable at all. I feel very agitated and restless and angry, but at the same time, I feel there's pain in my legs and in my hands. I don't know what to do. I'm not depressed. Huh? I'm working. This is what he will say. And when a person is stressed, all forms of therapy from yoga, exercise, etc. are very important. But if those things do not really help the person, no harm in giving a short course of tricycling, preferably dosalpine, because amitriptyline has a lot of adverse effects and very few people would tolerate. Above the age of 45, do an ECG for both. After that, it's important to treat stress with non-pharmacological methods. Next slide. So, well, brain could be having a million neuroreceptors, but we have only discovered a few. And we still have the same hypothesis, which we have been using for a very long time. So now NMDA receptors and other reasons for depression and pain. There are also inflammatory reasons for depression, and so a lot of newer findings are coming to the fore, and we'll learn more about depression in the days to come. But three take-home points as I close. Number one is physicians should treat simple depression not associated with suicidal thoughts, not associated with bipolar disorder, not associated with substance abuse or post-traumatic stress disorder, or not associated with any other psychiatric comorbidity. But when you see patients of myocardial infarction, when you see patients of stroke, when you see patients of kidney disease, and when you see patients with chronic physical illness like rheumatoid arthritis, etc., please screen for depression. Please understand that all that pain of rheumatoid arthritis is not the pain of the joints. A lot of pain is psychological, and this can be treated along with the medications for rheumatoid arthritis by tricyclics. My dear friends, myocardial infarction with pain in the chest, it may not be relieved by benzodiazepines. It is relieved by a tricyclic, not by an SSRI. Anxiety associated with post-myocardial infarction is relieved by a tricyclic. So treat depression in myocardial infarction, in stroke, and in other cases. You'll find that the longevity of life of those patients improve. The heart also improves along with the mood, and when the mood improves, the heart improves. With this, I would say, please treat depression. Psychiatrists are meant to treat complicated depression. You physicians should be actually treating simple depression. As I close, I still remember this patient which came to me 2 days ago. Again, 61-year-old patient, walking up and down at night and not sleeping, and saying that there's pain around the ribs all the time. All investigations were very normal. 2 days ago, when they actually came to me, I checked the physical contours, all the parameters are normal. I gave her a combination of a tricyclic, prosalpine, and nitazapine. She had not slept for a few days, 5 6 days. She slept yesterday for 12 hours. He feels a little better, but the agitation has not gone down. The pain has gone down. So pain can be associated with agitation. You need to understand that you need to differentiate anger from agitation and anxiety. Agitation is subjective feeling of restlessness, not caused by any medications, and restless in the mind and the body. And she has responded well, and probably in the next 1 or 2 weeks she'll be doing good. With this, I stop. Treat depression, save lives. Prevent suicide, save lives. Thank you. Thank you. we have lost a lot of time, so I would want to hear a lot of questions.
Hello.
Um,
Hello.
We can hear you, Dr. Thakkar.
All right.
uh, so actually, there are two devices that are on, I
Oh,
think, from your end.
now only one
Yeah.
device.
Okay, perfect. Now we can hear you loud and clear.
Now,
So I think now to have the questions. Do we have any questions that have come in? But before they can come in, I have a few questions, and I think let's throw the field open straight away, because we all know, and now it has been amply proven, that unquestionably there is this yo-yo which exists with pain, and this problem of which drug to use, how we can look at things, and how we can use. I want the neurologist and the psychiatrist to tell me about what would you use as the first line of treatment in this chronic pain episode.
Rahul?
Yeah, if you ask me, I would probably try and see what is the cause of chronic pain. Obviously, if it is a neuropathic pain syndrome, then I would try and use either an antidepressant, which is typically a TCA, or an anti-epileptic, especially if the pain is like a neuralgia. You know, those neuralgic pain syndromes like trigeminal neuralgia or post-herpetic neuralgia, those are the ones which do not respond well to TCAs. So those are the ones where we have to use the drugs like anti-epileptics, and the commonest drug that we use there is either gabapentins or pregabalins. Earlier days we used to use carbamazepine, but we're not using it more often. And of course, TCAs would remain the drug of choice for rest all chronic pain syndromes. I'm not talking here about other pain syndromes like osteoarthritis, which is purely a nociceptive pain, where probably an NSAIDs will be the drug of choice, and those patients probably won't come to us. But otherwise, if I get a pain syndrome, and to be honest, if I don't understand what is the type of pain, my first choice is to give a TCA and tell the patient that let's see whether you improve in a period of a month or so, and then call the patient back after a month. So my first choice is always TCAs. In a day, probably I write at least 10 to 15 TCAs.
So great. So TCA preferred over SSRIs. Now,
No doubt
before
about it.
Dr. Shetty comes in to answer that, I want a juicier question to be answered by him. Chronic pain causes depression. Is it a cause or effect of brain reorganization?
You're asking me?
Yep.
I would say, I do not know. I would say if it's associated, if there's an association, because we might split hairs at what came first. If there's an association, my choice of medication is first dosalpine, second amitriptyline, and third duloxetine. But let me tell you, 25 years ago, people would tolerate amitriptyline without a fuss, because the tolerance to adverse effects was much better 25 years ago. Now the tolerance to adverse effects are very less. A dryness of mouth or a constipation can make the patient drop out and go to another physician. So I would prefer dosalpine first in a good dose, amitriptyline, imipramine I would not give, and third would be duloxetine. But if the depression is if the depression is reactive and the pain is because of a reactive factor, in the absence of a past history of depression, in the absence of a family history of depression, there's a trauma all around and it's reactive, low dose and counseling and psychotherapy. If it is family history of depression, if it is because of a delusion that I have an illness and I have pain, like that lady said, I have cancer of the stomach and I have pain, I would give a good dose of a tricyclic, not attempt any counseling, and should better. In the COVID environment, very important. In the COVID environment, inside the hospital, some patients don't sleep at all. Intractable insomnia. Very important to give, if she's healthy or he's healthy, to give a small dose of a tricyclic in close consultation with the physician, so that the patient would not sleep excessively and his oxygen parameter should not go down. And a small dose of benzodiazepines. But if there is intractable insomnia, I would prefer a tricyclic in consultation with the physician who's treating. Fourth, in COVID era, as they come back, 1 out of 3 patients who have been in the hospital for more than 10 days, especially in the ICCU, they have pain all over the body. And they ask us one question, ये COVID है या आपका field है? And they don't come to me straight. They have gone to the physician. Physician said, I'm tired of his pain. So please go and see a psychiatrist. I had a BST employee 2 days ago. And he said, I have come out, I'm fine, but I have pain in the calves and I don't sleep at all. Can you help me? I said, I would treat this as depression. I would not use post-viral depression, etc., etc. And I don't use the word fibromyalgia at all. It's all mood.
Great,
And a lot of COVID patients need tricyclics post-COVID.
All right. Dr. Kulkarni, what is the role of dozolipin in migraine and tension headaches? Because we see a lot of the migraine and tension headaches are outside the hospital. The first spectrum was already elucidated by Dr. Shetty.
I would definitely use TCS as a first line drug in migraine. Tension type headache, there's no doubt. 80% of the tension type headache, maybe more than 80%, treated with TCS. As far as migraine is concerned, yes, TCS would be used in some of the migraineurs. I would use in migraineurs who have problems with sleeping, who have problem with depression. That's where we would use TCS. And I use a lot of dothiapine or dosulpin in these patients along with amitriptyline as well. Of course, for migraine, we have other agents also, like beta blockers and topiramate, etc. So those would be used depending on the comorbidities. So simple answer to your question is, in migraine, the choice of agent depends on the comorbidities, not on the headache. Whether it is a male or female, whether patient is not sleeping, whether he wants to gain weight, whether he wants to lose weight, whether he wants to sleep more, whether there's a depression, whether there's a hypertension, whether there is anxiety, then we would decide the drug. But if it's a simple migraine, then probably my drug of choice is usually TCS. In tension type headache, it is always TCS. And amongst TCS, I would be saying that dothiapine or dosulpin versus amitriptyline, 50-50 from my side.
So I would now move to what is the problem in the metabolic era, diabetic neuropathy. Both of you can answer, but since we are with the neurologist, you will kick off first. Diabetic neuropathic pain. What is your choice?
So that's again a disorder for which we use both drugs, the TCAs as well as anti-epileptics. Both the drugs have been used, and there are trials of use of combination also. So I would start with one drug, either TCAs or an anti-epileptic. See whether the patient is responding. If there is response which is suboptimal, probably I would try and use a combination. And there is good amount of data about combination of these two agents also, and there's a scientific data. So I would go for this. I don't use topical agents. I don't like to use topical lignocaine and topical capsaicin. I don't use much of opioids. If the patient has got pain which is rapidly worsening, or if the pain is getting, like a patient is getting intermittent attacks of pain, that's where I would, as a third agent, that is tramadol. Tramadol is useful in those kind of attacks. Sudden worsening or acute worsening, that's where tramadol helps. No other NSAIDs would help. So these are the three.
Shetty.
Hemant, 1 out of 4 to 1 out of 3 patients who have diabetes have depression. Now, it's important to differentiate the pain associated with depression and neuropathy. If there is pain associated with depression, go ahead, treat depression aggressively and get him or her out. Also, maintain the sugar levels. Use a lot of psychological approaches like helping the relationship in the family, exercise, because behind pain, there's also a story apart from the neuropathic pain. So it's important to heal the story also. At the same time, pregabalin also is a drug which we use, but if it's severe neuropathic pain, I would ask my physician to treat the same. When the pain doesn't abate with any medication, anything, we teach the patient to lower his or her expectations and accept some part of pain as part of life. So that is also one of the tools we use with such patients. Thank you.
So I will have to now invite our co-host Swapnil Vade to continue, because 9 o'clock is my Cinderella time. I have to take a con call with somebody else. And I hate to leave this boxing arena where I have two great partners vying for the trophy of pain. I don't want them to become anxious or go into depression. Swapnil, put on your camera and take over the questions. This is something that can go on and on till the cows come in, but you have another 10 minutes because our all delegates have to have their dinner too. Swapnil, over to you. Thank you, everybody.
Thank you, Hemant, for being there.
Over to you, Dr. Saxena, please, right now. Dr. Saxena, please.
Yeah, so we come to an end of a very interesting session on basically pain management and had views of two eminent personalities. And basically, we came to know that how depression is playing a role and how pain is creating the depression and how to break the cycle and what to use and when to use, and was nicely moderated by Dr. Tucker. And I want to thank each and everybody who was present
Before
in
you thank,
today's program.
sorry to interrupt that in between. Before you thank Dr. Saxena, asked to our eminent speakers from a physician's angle on pain.
Okay, all right. So basically, as a physician, and we encounter these mild and moderate cases of depression presenting as somatic complaints in our clinics. And as Dr. Shetty said in the very beginning, that the physicians should manage mild depression. So it is very common problem in our clinics that patients, even if they are suffering from chronic diseases nowadays like diabetes, hypertension, or cardiac disorders, or anything like that, there is some functional overlay or element of depression which always is there and is very difficult to treat even if you treat patients for their ailments. So it was very nice, and from both the experts we learned that what drugs can be used. But I would like to know basically that there should be more awareness in the physicians about the basically the diagnosis of depression, which is commonly overlooked. So what scales or scores or objective assessment do you suggest that the physician should keep as ready reckoner in their clinics to diagnose that kind of problem?
Uh, Thank you, Puneet ji, for that beautiful question. Uh, every physician should keep the patient health questionnaire, which is a self-rating questionnaire, in at least 12 languages validated in the country. That is a screening questionnaire for depression. If the screening shows that the patient has mild to moderate or moderate to severe, and if it's severe depression, see that you see the patient as a last patient so you can spend time and check whether it's depression associated with suicidal thoughts or not and start giving antidepressants. That's number one. Number two, if it's a patient who has scored very high but has a severe psychosocial stress, and he or she, you cannot sit down with the patient for a very long time, give a chemical support, but see to it that they go to a psychologist or a psychiatrist. And if you follow these patients for a long time, you learn the art of treating depression, and that I think is very important.
So another thing is that what I see in my practice is that it's very easy to put patients on antidepressants or maybe anti-anxiety medicines, but then to take it off, it becomes really difficult, and it becomes that the patient craves for it, and it continues for long time. Even when the primary ailment is cured, the patients keep on using those kind of drugs. So, any suggestion for that, basically?
Absolutely. If you have seen a patient in the first episode of depression, he or she would want to stop the drugs at the earliest. I mean, that is the most powerful drive of the patient is, ये दवाई से कभी छुटकारा मिलेगा. Be very clear that you will be better in 4 to 12 weeks, but maintenance dose is at least 9 to 12 months after you recover. And just as we put coolant and oil in the car after 5,000 kilometers, you may have to take the dose. Now he will drop out because he's better. Make a phone call to the patient and find out how is he, because in a relapse, he may have suicidal thoughts and he may actually lose his life. At the same time, at least in Maharashtra, you can't get psychiatric medication so easily. So we are able to monitor. But all those patients whom we have given a good dose of antidepressant, please monitor the patient. If you have started anxiolytics with an objective to bring down the anxiety, it's important to see to it that you withdraw the anxiolytics at the earliest slowly. And if you're given alprazolam, it's difficult, but clonazepam can be withdrawn. But all the same, if somebody has a chronic depression, chronic pain, what is the harm if he takes antidepressant, tricyclics, for an indefinite period? No harm at all, because he requires it. Now, this is not addiction because he does not increase dose. He takes the antidepressant, he feels good, he becomes functional, he can smile at his husband or his wife, and he can go to work. So nothing wrong in maintaining patients for a long time on antidepressants. But Punitji, every physician should supervise it. If the patient has not come back, please give a call after 3 months and tell him that you can come. I'll not charge you, but please come and show it to me. So supervision
That is
is
the
important.
so that is the problem basically, because the follow-up is not strong, and basically adjusting the dose or maybe weaning off the patient is not taken care of adequately. And there is another disturbing trend which we see probably sometimes coming from periphery, that there is an inadvertent use of anxiolytics and antidepressants even if the patient is
Absolutely.
not requiring. So that is
So, no,
also a big
and
problem, because once
no,
patient gets used to get the good kick out of it, no, so he is averse to leave that. He is ready to leave all other medications, maybe for diabetes and hypertension, but then he wants to continue with clonazepam or that kind of medicine.
3 points,
So
sir. Patients also take antidiabetics without your supervision for a very long time.
yeah,
Unless they become they have
yes,
glycosuria or they become hypoglycemic. But benzodiazepines come under the NDPS Act now. It's not under Schedule H plus or Schedule G. They're supposed to be sold very carefully, though it may not happen across the country. And as of now, telemedicine is only allowed clonazepam, but that is something to do with the regulatory body. Maharashtra is very strict, and I agree with you, sir. If you prescribe benzodiazepine, if you have control of the patient, see to it that you taper it as and when essential. But chronic generalized anxiety disorder, chronic panic, if they're taking 0.25 clonazepam for a long time, कुछ नहीं बिगड़ता. And what happens, sir, after we attend a seminar like this, or if we attend a seminar where the speaker is very
that is
paranoid about
practically
particular,
happening. That is practically happening.
so I'll
The
tell you,
people are getting benefited because of that,
so
and
I'll tell you
you
what
won't
exactly
believe that
happens. I'll just
as
finish.
physicians, probably we are writing as much of anxiolytics or antidepressant as probably psychiatrists are, or maybe more than that. So
Please do it if it is valid, sir. But 20 years, if somebody is taking 0.5 milligram of clonazepam, and suddenly he has heard in the TV he addictive, he comes to the physician. And physician also has attended a couple of talks. Please don't give benzodiazepine.
obviously,
If he has
the
taken,
quality of life is more important. Yes,
if he has taken for
quality
20
of
years,
life is
please
more.
don't stop, sir. Please don't stop. If you stop it, there'll be immense problem, and there'll be withdrawal symptoms. And also, what is very important is probably they are not addicted to it. They require that 0.5 milligram, and they're not able to stop because addiction would need dependence and tolerance and increased dose. I would be very liberal and say if they're taking for 25 years, I would allow them to take as long as the other physical parameters are important. But physicians should learn to treat depression. It's happening all over the world. India should also follow that same
Yes.
pattern.
Basically, it is an integral part of the disease process. So we
Absolutely,
have to
sir.
learn that. Yeah.
Absolutely.
Yeah. So, any other comment from you, Dr. Kulkarni?
I totally agree that one should know about treating depression, and I am sure that the Indian Psychiatry Association has said that mild depression is not a psychiatric disease; it is a physician disease. It has to be managed by, and of course, we see as a neurologist little different disorders. we see pain related depression a lot, chronic disorders associated with chronic disorders like Parkinson, dementia, they get depression. So we use these agents, both SSRIs as well as TCA. These are simple agents to use. You can use them for indefinite periods. They hardly cause any major side effects. So be liberal about their use. In the current COVID era, of course, one alternate patent, if you write blindly any antidepressant, you are doing good for the patient. You write just drug as a last drug in this COVID era, it is we are doing good for the patient. So it's a very common disorder and very under recognized disorder. One must know how to treat this disorder.
Right, very rightly said. So I think it's time to conclude today's program, and it was very nice and interactive thing to learn, and it's a very practical significance. Today's topic was it was very significant for physicians who are practicing day in day out and seeing patients of depression and pain, chronic pain, and generalized anxiety disorders. So with this, I thank all the our guests, Dr. Arul Raj, Dr. Paul, who took out time and uh, said about the roadmap of the healthcare in India, and then Mr. Anil Joseph from Abbott for supporting the academic cause and telling us more about Abbott. Then our eminent speakers for today, Dr. Harish Sethi and Dr. Kulkarni, and Dr. Thakkar, who moderated this session so well. Then I now invite Jyotish from Abbott to finally propose vote of thanks to everybody. And I want to thank all the delegates who have joined in and have attended this program. Thank you very much.
Thank you so much, Dr. Saxena. It is indeed a pleasure to have a friend and brother like you, both in the professional and and personal life and journey. Thank you so much, Dr. Saxena. So I would like to start with Professor Arul Raj, the President of Associations of Physicians of India, for his support, help, and guidance for the entire program. Thank you so much, sir. So I would also like to thank today's chief guest, Professor Dr. V.K. Paul, who has managed his busy time schedule to address the entire gathering on Associations of Physicians of India platform. Thank you so much, sir. Thank you so much, Dr. Paul. I would also like to thank Professor Dr. Shashank Joshi. He has joined us in between for some time, and he is also an elder brother, to me, and for his guidance always. Who is the dean of the Indian College of Physicians. I would also like to thank Dr. Mangesh Tiwaskar, my elder brother, who is the astute Secretary General of the program, and who has made the program so well for the benefit of the fellow physicians. I would also like to thank our today's faculty, starting Dr. Hemant Thakkar, the proficient moderator for this session. Everybody knows about his credentials, and he is well-known physician in the country. Dr. Harish Shetty, who is better than him to address basically today's crowd on a special topic like this. Thank you so much, Dr. Shetty. It is an excellent pleasure to have you always on board. Dr. Rahul Kulkarni, thank you so much, an astute neurologist from Pune. Thank you so much, for your contributions and for your astute presentations which has been given, and so much of light in the area of pain management and neuropathic pain management to the participating delegates. I would also like to thank the entire team from Abbott. Especially from my colleague from the medical team, Dr. Sripada, the medical director from Abbott, Mr. Anil Joseph, most importantly, our leader, the managing director and general manager for Abbott India Limited. My other colleagues from the medical team, Dr. Diotana, as well as our teams from medical affairs. My team, from commercial folks headed by Mr. Anuj Mehra, who is heading the NeuroLife team from Abbott, marketing head Deepak Singh, and my other marketing colleagues, including Dinesh. So I would also like to thank the entire team members headed by Smita from Wood Factor for doing the logistic coordination so right, for bringing us this platform live today to many physicians across the country. Thank you so much. Thank you everybody. But before you switch off, I would like to request your presence in the upcoming webinars on 3rd and 4th of October. The 3rd October program is on IBS, and the 4th of October program is on vitamin D. And it already request to all the delegates to kindly provide the DR and MCI registration number, because this the platform provides the credit point as announced by API. Thank you so much. Thank you so much for the entire faculties, API for the collaboration, my teams. Please do tune us on 3rd and 4th October, prime time, prime show, API DIAS. Thank you so much.